Quick disclaimer before you listen. The World's Okayest Medic Podcast is an educational and commentary platform produced and recorded by me. What we say on here is not endorsed by any of our employers, and we are not speaking on behalf of our employers. Our commentary is our own. Finally, remember to follow your local protocols.
This is going to be short. I wrote this right off the cuff. I have no references. I did no research nor deep diving into the topic to prep. This is a case study. I think there's some good lessons to be learned. You may remember the reel I did the morning after the Super Bowl where I talked about how I had this super drunk guy from an MBA and how I thought he was just really, really drunk. But I went through the motions of working him up as a trauma, and I took him to the trauma center just to be safe. And thank God I did, because he ended up crashing and burning, and he was indeed a major neurotrauma. Catastrophic neurotrauma, in fact, because I read his obituary in the paper a few days later, and it doesn't get more catastrophic of a head injury than that. I don't think I need to elaborate any further, but let this be a good lesson, yet again, to not go down the pathway of thinking that your patients are just drunk. Yes, they may be just drunk, but it is, in this instance, I opine, another example of why it's better to be safe than sorry and to not just chalk up significant mental status or neurologic findings to just being drunk. It goes along the same vein as not going down the, oh, it's just anxiety pathway. That's an alluring pathway to go down. It's easy to do, but it's a great way to step on your dick. So let's recap with the case study. It's Super Bowl Sunday. I live in the Philadelphia area. I work in the Philadelphia area. It's the big game. Everyone's partying because we are dirtbag as Eagles fans. Everybody's drunk. Around 8 p.m., I get dispatched for an ALS accident. The CAD notes are vehicle versus pole, one male patient unconscious. As I'm responding, dispatch provides an update that says that the 911 caller is still on the line and that the patient is now conscious and seems to be drunk. I arrive shortly after. The BLS unit is already there. I find a car that did indeed take out a telephone pole. It completely sheared the pole in half. The car has moderate damage. I mean, it's probably totaled, but I have certainly seen worse, and you have probably seen worse too. There was significant front end engine block damage, but there was no intrusion, no scarring of the windshield. Airbags had deployed. There was no steering wheel deformity. As far as mechanism, yeah, it was significant. The guy sheared a telephone pole. That takes a lot of force to do, but we've all seen much worse. So the BLS crew's there. They're moving the guy out of the car and they're getting him onto the stretcher. And the first thing I notice is that the whole scene, the guy and the car reek of alcohol. When I looked in the car, there's beer cans strewn about and there was an open 30-pack of Coors Light. It looked like this guy was just guzzling beers as he was driving down the road. So the guy's awake. He's responsive, but he's very altered. He just seemed very, very drunk. He was generally listless, but he did follow simple commands and he responded to verbal stimulus. And when you would ask him a question, he would respond like a very, very inebriated person. Be like, hey, what's your name? He'd be like, where are you right now? So we put him in the ambulance and he starts vomiting. Great. This is going to be a treat, I think. I'm like, oh, this is, you didn't even make it to halftime yet, buddy. I think he's just drunk. I really did. But to be safe, I made the decision to do the whole trauma workup thing, bypass a closer community hospital to transport him to a trauma center. And I did the pre-hospital trauma alert notification. I cut him naked, C-collar, IV, the whole workup. And when I cut him trauma naked, he had absolutely no signs of injury. I palpated his head. He didn't have a contusion, nada. So long story short, it's about a 30-minute ride to the trauma center, and he steadily started to decline mental status-wise. He stopped responding to verbal stimulus. He kept vomiting. He didn't projectile vomit. I think that term is overused. Everybody says, oh, they projectile vomited, but he didn't projectile vomit, but his vomiting got more aggressive, I would say. And at first, when he became less responsive, I thought, all right, he passed out drunk. The puke smelled and looked like beer that had just been consumed. It actually smelled like pretty fresh beer. Like if you took a beer can and dumped it out on the floor of the ambulance, that's what the vomit smelled like. I did, though, pretty quickly come to the realization that, yes, this guy is drunk, but I think there was some anchoring bias that was making me think it was just being drunk, and that made me think, oh, Mike, you're just going through the motions, working the whole trauma thing. But I did come to the realization, hey, this guy's got something going on. He does indeed have a head injury. So I called the trauma center. I recommended a pre-hospital, what we call a trauma alert in my area. Everyone has different names for it. And after I called, we were probably 10 minutes from the hospital at that point, and he began to have bradycardic episodes. His blood pressure, he was already a little bit hypertensive, but his blood pressure was trending up as his heart rate was trending down. The Cushing's reflex, that's a sign of increased intracranial pressure. And by the time we pulled into the hospital, he was exhibiting decerebrate posturing, which is where it's extension posturing. So decorticate, you turn inwards like that. Decerebrate is lower functioning posturing. They say it indicates a higher level of brainstem dysfunction. It was a very rapid decline. So now some people are probably thinking, hey, how come you didn't intubate this guy? Well, I certainly thought about it. He didn't initially look like he needed to be intubated. Also, this accident geographically happened not far from the Delaware state line, and the trauma center is in Delaware. We quickly were in Delaware once we left the scene. Under my protocols, I need 2 Pennsylvania ALS providers to do a drug-facilitated intubation. I can't use an out-of-state Delaware provider to do it. Politics, I know. You're preaching to the choir. I wasn't going to sit on the side of the road and wait for another Pennsylvania medic to come from God knows where just to push meds and intubate. The guy precipitously got worse, and by the time I was thinking, geez, this guy needs to be intubated, we were already halfway to the trauma center. So I propped him up on his side with the head of the bed elevated a little bit, and while it was gross, he kept his airway clear, and he kept a good pulse ox because he just vomited off the side of the stretcher. That worked fine for airway maintenance. Optimal? Maybe not, but it worked. If I had another medic with me, then yeah, I probably would have tubed him at that point because I think it was warranted. But me by myself, I didn't do it. I could have tried, but me just raw dogging it without drugs and shoving a laryngoscope down his throat sans induction meds is just going to raise his ICP even more. It's going to make me miss the tube, and it's going to make him puke more and aspirate. It just would not have been good just to get a tube. All right, so the big lesson of many lessons here, I think he had an epidural hematoma. Now, I never got follow-up on him other than the obituary. Why do I think he had an epidural hematoma? Because he exhibited the textbook signs and symptoms and progression of an epidural hematoma. An epidural bleed is an arterial hemorrhage. Subdural hematomas, which are far more common, they involve these really tiny little bridging subdural blood vessels. They are slow venous accumulations of bleeding, and they may take quite a while to manifest symptoms. An epidural bleed involves the middle meningeal artery. As we know, our arteries are under high pressure and they bleed a lot. So the patient with an arterial head bleed is going to rapidly experience symptoms and they're going to rapidly decline. So the classic presentation is that the patient gets a blow to the head. Often it's the side of the head because of where the artery lies, and they lose consciousness because they've suffered this big blow to the head. They then quickly regain consciousness and they have an intact mental status despite the artery being ruptured. So why doesn't the artery just start dumping blood into their intracranial space? Well, when arteries are damaged, they clamp down and they spasm. So the patient is probably going to be having a hell of a headache, but they aren't really bleeding into their intracranial space because that broken artery is clamped down. The brain remains perfused somewhat because of the whole built-in vascular redundancy, the circle of Willis thing. So the patient will present with an intact functioning brain and intact mental status, or somewhat intact mental status. Often they say they're GCS of 15, complaining, hey, I'm all right, I just have a headache. Eventually, the catecholamines are going to start to wear off. They're keeping that vessel spasming and clamped down. That spasmed artery is going to relax, and boom, that artery is going to start hemorrhaging. And since it's an artery, it's going to bleed a lot. That's going to form a large collection of blood that is going to rapidly expand, and it's going to push brain tissue out of the way. which increases the intracranial pressure, the whole Monroe-Kelly doctrine thing, and eventually that's going to lead to herniation without rapid neurosurgical intervention. If you're taking the FPC or CFRN exam, you should know that on CT scan, epidural bleeds have a sharp edge and a lens-like appearance. They call it lenticular. So let's close out and go back to my guy to quickly recap. The guy is in this accident. Despite having no visible signs of injury, he must have banged his head. He lost consciousness, hence the 911 caller advising, hey, I just saw this accident. The driver is unconscious. He then wakes up from his transient initial loss of consciousness, and despite being really drunk and a bit altered, he was responsive. He stayed like that for a bit while his middle meningeal artery was clamped down, spasming, not bleeding. During transport to the hospital, he precipitously got worse as the catecholamines began to deplete and wear off, and that artery stopped spasming, relaxed, opened back up, and dumped blood into his intracranial space. He got less responsive as that blood is accumulating and pushing brain tissue out of the way. And he gets less responsive as it keeps getting bigger and bigger. And then eventually he's going to herniate and exhibit signs of herniation like he did, like aggressive vomiting, bradycardia, hypertension, and eventually posturing. So no bueno, but a good lesson nonetheless. That is a quick recap of that case and epidural hematomas. That's what I got. Real quick podcast, but I wanted to get this out there. Talk to you soon, everybody. Thank you.